Thanks everyone for joining. I'm John Lynn, the founder and chief editor of Healthcare IT Today. We're excited to bring you a great discussion around interoperability and the challenges of interoperability in healthcare and how to solve them. And our guest today is Drew Ivan. He's Chief Product and Strategy Officer at Lyniate. Welcome, Drew.
Thanks for inviting me.
Yeah, great to have you here. So tell us a little bit about yourself and Lyniate, which is a new brand. So I think a lot of people probably haven't heard the Lyniate brand yet. So tell us about yourself and Lyniate.
Yeah, Lyniate is the merger of two companies, CorePoint Health and Rhapsody. Rhapsody itself was a carve out from a larger business about a year and a half ago. So both products have been in the market for about 20 years, so they have good brand name recognition. But when we brought the two companies together, we decided that we wanted a new brand name, and so we came up with Lyniate. The merger obviously got a lot of attention because CorePoint and Rhapsody were recognized as two of the most prominent integration tools in the market.
Yeah, definitely. When I saw it happen, I was like, wow, that's bringing two power players together. So, it's great that you're working on it to help solve the problems of interoperability. So, I mean, on everyone's mind is COVID-19, the coronavirus. So, what have we learned about interoperability in this time of COVID-19?
Yeah, what we're finding among our hospital customers is their immediate focus is more on the equipment and the supplies that they're trying to get. Among our public health customers, we have a lot of customers that are state departments of public health. We find that their interoperability needs focus on getting data mostly from laboratories to identify reportable cases of the infection, and then roll that up and report it through to CDC.
That's great. And it's interesting, a lot of people hammer interoperability as not happening. And we experience it as patients often when we have to do duplicate forms and other things. But I always think when that discussion happens, sure, it's impacting them individually, but yet I hear stories of millions of transactions going across the wire. So where are we seeing interoperability today?
What we found is that interoperability means different things to different audiences. And one audience is the hospital or IDN audience. When interoperability is taking place within a single organization, we're talking about tying together things like the clinical and administrative systems that are in place to provide patient care, the billing system, the EMR, the registration system, laboratory systems, and radiology systems, and so forth. Tying those all together is what we call organizational interoperability, and that's been happening for a long time. Products like CorePoint and Rhapsody have been doing that for 20 years. Where we are starting to see some movement in interoperability is in a couple of other areas. One area is in device interoperability, so that's getting data from the medical devices, or these days it may be a remote patient monitoring device, or in some cases even a consumer grade device. Getting the data off of those devices into clinical systems like EMRs is another class of interoperability. And then we have the cross-organizational interoperability. So this is the ability for hospitals to communicate with one another, or between hospitals and payers, hospitals and public health, anything that where the data has to span across organizational boundaries. This is an area of recent focus, including with the ONC and CMS rules that have come out. And then the final area of interoperability that we think about is really interoperability between the data holders and the patients. And this is one that hasn't gotten a lot of attention historically, but is starting to gain some traction now that these new rules from CMS are out.
Yeah, I mean, I think you're right that the CMS has made it clear that the patients need access to the data, which I think is a major initiative and something that should have happened long ago. What are you seeing in the 21st Century Cures Act, or the interoperability final rule, as many are calling it? How is that impacting the work you're doing to help across all three phases or types of interoperability?
Yeah, so what we're seeing is a mandate to increase the types of interoperability that I think everyone assumed would come along for free when data moved off of paper charts into electronic medical records. That's a process that we've been working on for over 10 years. What we found was that just because the data is electronic doesn't mean it's liquid, and we needed that extra mandate to to enforce the movement of data across organizational boundaries, as well as from the silos that they're in out to the patients who they pertain to. So one thing we're seeing is an increase in interest in these types of interoperability. Another thing that's unique about these rules is that they actually specify a technology. It's rare for a rule from HHS to say you must use this specific technology, but they've specified FHIR version 4. And so that means that a lot of our customers, even the ones that are good at organizational interoperability, they mostly have expertise in HL7 V2. And so it's a new learning experience for them to be able to implement these interfaces based on FHIR.
Yeah, that's going to be a big change for a lot of organizations. I think it's going to be interesting. I think I wrote 7 or 8 years ago, why don't we blow up meaningful use and just use that money to incentivize interoperability, because there's no way you're going to be interoperable without an EHR. So you'll essentially incentivize EHR through interoperability. I wonder if some money could come from COVID-19 to help incentivize it, because I've often said as well that interoperability doesn't have its own natural reimbursement, if you will, or financial motivation. In fact, in many ways, many organizations have told me, well, if we become interoperable, that's a risk to our business and could actually hurt our bottom line. So, yeah. Anyway, I just conjecture around it. But what is the reasons that you see most people going this direction and taking part in interoperability? Is it regulation, or is there other motivations?
There's always some combination of business motivators and regulatory motivators. Anytime there's a financial driver for interoperability, those obviously happen first, right? The first kind of interoperability we got in healthcare was the ability to send claims electronically, because that had an immediate impact on the bottom line. The places where we're seeing slower adoption is, as you're talking about, in places where perhaps competing medical systems need to exchange data. We're starting to see that, some business drivers to make that happen as you get into the ACO type models, where different organizations need to cooperate because they're mutually on the hook for taking care of a patient. So that's a strong business driver for exchanging data. But to get that last segment of the market to exchange data, it's taking these regulatory measures to get them over the resistance to transferring data.
Yeah, that's great. Well, I think a lot of people would love for interoperability to happen, especially patients themselves. But, I think people like you kind of indicated, we're a little naive that if we just turn it electronic, that should provide liquidity. So what does it really take to make interoperability a reality in your experience working with these organizations?
Yeah, so ideally it takes a business driver, like we talked about, but it also takes a lot of focus on standards. So there's good standards organizations like HL7 and IHE that are putting a lot of work into thinking about the workflows, the data formats, and the interoperability patterns that need to be realized. And they're encoding this work into the standards, and that makes every interface that happens after that a little bit easier to tackle. Because if you just think of every interface as a brand new thing that you're building from scratch every single time, maybe that one interface will be faster to build. But if you look at the amount of effort in aggregate, you're going to spend a lot more time doing that than if you build a standard first and work to the standard. So I think the other key piece is a robust standards ecosystem. And we're lucky to have that in healthcare. We have HL7 version 2 document style standards around CCD and CCDA, IHE style integrations, and the latest one, of course, is FHIR.
Yeah, I mean, we might need a follow-up video to talk about standards and are they enough and where are they falling short. So we'll have to have you back again.
Yeah.
But it's interesting. Those are some good suggestions on what makes it a reality. I think the business driver is key, because then that creates organizational commitment. But are there also some signs that you've seen on projects you've worked on where you know that interoperability project isn't going to work because of insert in the blank? What are the things that when you see that you're like, maybe we shouldn't bid on this contract, or we need to solve that before we proceed?
Yeah, I mean, it's never the technology, because where there's a will, there's a way. If there's a sufficient motivation to get two systems talking together, you can find some way to hook them up. what you can really identify as a red flag for any integration project is the willingness of the participants to cooperate and the business drivers behind the project. So if there aren't the business drivers, if there's not a willingness to cooperate, then those are the types of projects that won't succeed. And they might not fail outright, but they may drag on for so long that they become irrelevant by the time they're complete.
Yeah, that's terrible to think about. Well, I think I know the next business driver of this, I think, is going to be COVID-19 data that's going to need to be shared. So you know who's been infected, you know who's been tested, you know who's been treated, you know who's received the vaccine,
Yeah.
eventually the treatments. Is that the next wave, or you know, what do you think about that? As far, I mean, that feels like something that's going to need to be interoperable, or we're going to have problems. Of course, I think that's still probably 2 months down the road at least.
Exactly.
Any thoughts on that?
Yeah, I mean, unfortunately, a lot of the regulations that are in the rules that dropped last week would be really helpful to have right now. So,
Yeah.
you know, there was kind of a race between the pandemic and publishing the rules. If the rules had been out 6 months earlier or even a year earlier, then we might have a much more robust infrastructure in place to be able to do things like sharing the patient data across organizational boundaries, but also, you know, one of the rules is about ADT alerts. When a patient shows up with
Yep.
a certain diagnosis, you need to alert other stakeholders. That's in the rules, but the deadline is 6 months from when they become finalized. So by that time, it may be too late to help the current pandemic, but it'll be in place for future patterns.
Yeah, I agree. And I think months from now, this problem is only going to become worse. So your insights on how to make interoperability a reality is really useful. And thanks for sharing them. And we'll certainly follow up as everything continues to evolve. Everyone, thanks for watching. We've been here with Drew Ivan, Chief Product and Strategy Officer at Lyniate. If you want to find more great healthcare IT content, check it out at healthcareittoday.com. Thanks, Drew.
Thank you.